I'd like to acknowledge and thank ANZGOG and Ovarian Cancer Australia for putting on this forum and for asking me to speak to everyone this late afternoon, and especially to thank you all for coming down on a late Saturday afternoon and coming to listen to some of the talks about future directions in ovarian cancer. And I know some have come from far afield, including Perth. So again, thank you for coming down. So my talk is going to discuss immunotherapy as a treatment for ovarian cancer, and the outline of some of the things I want to cover is just a historical perspective to how we came about to different treatments in cancer. So not just immunotherapy, but how we developed targeted therapies and chemotherapy, how we went from non-specific therapies that target multiple aspects or multiple organ systems, not just our cancers, to getting more targeted, personalized treatments, the evolution of immunotherapy, clinical trials in ovarian cancer, particularly as they relate to immune therapy, future directions, and how we hope to personalize cancer treatment, particularly again in the space of immune therapy and targeted therapies. So immunotherapy, or our understanding of the relationship between cancer and the immune system, has come along from the late 19th century, where Rudolf Virchow was the first to recognize a link between the immune system and cancer by simply recognizing some immune cells in cancer tissue. And that was the first step to go like, well, the immune system does play a role in fighting cancer. And it wasn't long after that, 120 odd years ago, where the first immunotherapy was actually used to treat cancer. This surgeon from New York, Coley, injected essentially bacteria around tumors that arise in the bone or the soft tissue, and found that there was significant regression in that tumor. And that was because that bacteria or those toxins were actually stimulating an immune response, trying to fight the infection around the tumor, and then also attacking the tumor too. And for 40, 50 years after that, there was a lot of attempts at trying to use that treatment, but obviously it had other issues because it was essentially injecting infections, and therefore there was a lot of issues with complications from that. And then targeted therapy, and really the first coining of the term chemotherapy came from Paul Ulrich in the early 20th century, and he was the first to describe cells that have receptors on them. A receptor is essentially a flag or a plug on the surface of a cell that makes it recognizable or identifiable, and cells may have many receptors on them. And if we can develop a treatment, whether it's an antibiotic or an anti-cancer therapy, that can click onto that receptor on the outside of a cell, that can make it a so-called magic bullet or a targeted therapy against that particular cell. Chemotherapy actually came much later, and that was really not just the Second World War, but also the First World War, with really the horrors of warfare, chemical warfare, where soldiers were found to have significant reduction in their immune cells following the use of mustard gas. And research from the US defense research organizations came up with nitrogen mustard-based chemotherapy. It was actually the first treatment to treat lymphomas and leukemia as chemotherapy during the 40s and early 50s. So really, Ulrich's magic bullet was eventually realized when these three researchers were awarded a Nobel Prize in physiology in '84 for developing the first antibodies, so these drugs that click onto these little receptors or plugs on the surface of cells and create potentially the first targeted treatment. And they created those through animal models and in the lab, so mainly mouse. So these antibodies were derived from mice, and therefore when they were used in humans for the first 10, 15 years, it was a little bit more tricky because they didn't quite link up with the human cells as they would with the mouse. Nevertheless, the first magic bullet, the first targeted antibody against cancer, was approved in the late 90s against a form of lymphoma. Soon after that, another antibody was approved for breast cancer, and that is a target that that again sits on the surface of about 20% of breast cancers. And then soon after that, more and more of these targeted drugs, either against lymphomas and leukemias, against melanoma, and only on the 1st of February 2017 was the first targeted therapy tablet that targets a particular abnormality in some ovarian cancers that harbor a BRCA mutation. And then these treatments came thick and fast for the next 10, 15 years, and these are the numbers of publication year by year that describe developments in targeted therapies against cancer. So going from 85 to 2014, a significant increase in number of annual publications. Immunotherapy then continued to advance, and the Australian Sir Frank Burnett described the first theory that describes how the immune system protects itself from foreignness, so things that are not us when we were born. Cells in our body, immune cells in our body, are educated about all the cells that are human, that identify us, and recognize things that are not us. And that was called the principle of immune surveillance, where the immune system is looking out for things that don't belong there. And obviously that ultimately is what's leading to cancer immunotherapy. And there's really an immune system against cancer. There can be three areas or three phases of this. We can either have a cancer that is diagnosed, and if a cancer is diagnosed, that really means that the immune system has failed to attack that cancer, and that's what's called escape. So it means that the cancer has escaped, it's growing, and it is not controlled by the immune system. The other extreme, A, is elimination. That's where the immune system has managed to recognize the cancer, managed to attack it efficiently, and therefore able to eliminate it. And equilibrium might be a state that is in between, where the cancer is there, but it's kept in check and kept stable, potentially for long periods of time, by the immune system. And these three principles almost underpin all our efforts to try and optimize our immune system through all these new and upcoming drugs. So just to go over, a detailed slide a bit, but again, it's just to give you some principles that underline some of these treatments. So if you have a tumor cell, that tumor cell needs to be attacked by some form of treatment. And that can be just conventional chemotherapy, it can be radiotherapy, or it can be a targeted therapy. So any of these treatments that result in a death of a cancer cell, they will release some protein or antigen or something that is foreign, something that the body recognizes as not belonging to it, and that will be picked up by some other immune cells that then show it to the most important components of the immune system that target cancer, and they're called T cells, or it's called lymphocytes. And then when these are activated, they can multiply, they can go back into the tumor again, and can attack the cancer and eliminate it. And that circle, that cycle, is where all the immune therapies are trying to adjust, to tweak each of these 6 steps to try and enhance the response, to achieve that final step, which is to destroy a tumor, but also generate that immunity, that memory. So when we get vaccinated or exposed to chickenpox when we're young, we don't normally get exposed to the same viruses again because we've got these memory components of our immune system that can remember and protect us from that condition reappearing. And I'm not going to describe the cells, but I'll describe the first drug to ever be approved as an immune therapy for cancer. It's called Yervoy, or ipilimumab, and that was approved only about 4 years ago in Australia to treat melanoma. And that essentially is targeting one of those steps of the immune system. It's around step 3. And there's these switches that control some of these steps of that immune response. Some are positive switches, some are negative switches. So our immune system has essentially a gas pedal and a brake pedal, or many gas pedals and many brake pedals. If we are healthy and we're well and nothing is happening, then they're both in equilibrium. If we get infected, get the flu, get a virus, then we push the gas pedal and release the brakes so that the immune system can multiply and attack the infection. Cancers have learned to hijack those brakes. So some of the cancers are pushing down some of these brakes that slow down the immune response and tell the immune system, don't worry about me, don't attack me. And so the cancer can thrive. And therefore these drugs, such as Yervoy, are targeting those brakes and removing the brakes. They're releasing the brakes and therefore unleashing the ability of your own immune system to attack the cancer. And there is really no treatment that is as effective as your own immune system in targeting disease, including cancer. And the second antibody that has spent, well, not spent, but was discussed every few months on TV and other media sources in the last couple of years from melanoma is Keytruda, or pembrolizumab. And there's another drug, or more than one drug now, that target these pathways. And again, it is another really what we call checkpoint, another one of those breaks that is being released so that the immune system can be activated. So these major advances have been happening in melanoma now for a number of years. And what we're hoping for, and it is happening, is that these things transition to gynecological cancers, including ovarian cancer. And before I show you a few examples of clinical trials, I just want to quickly run through the basic steps and what different phases of a clinical trial are, because you might hear later on today about what a phase 1 clinical trial is and what a late phase or phase 3 clinical trial is. So when a drug is first used in human, so it might be tested in the lab, might be tested in animals, but when it's first used in human, that's called a phase 1 study. And that is usually a very, very small study where only 3, 4, 5 patients might be treated at a particular dose, watched very closely, and then if it's safe, the dose goes up to the next level until we find what is the safe dose. So these are called dose-finding studies. And then we go up to phase 2, where you expand the number a bit. We know what dose that we need to use, but we just need to see whether it actually works or not. So 100 people, does it work in 50, does it work in 30, and so on. And then phase 3 is that final phase before a drug can be registered, and that compares your new drug to whatever existing best thing you had before that. And these are the randomized trials. So a survival curve essentially is a beginning of every trial where everyone is alive, and this is a very advanced survival curve for melanoma. And everyone starts at 1.0, which is really 100%, but if the treatments aren't working, as time passes, people are dying from their disease. And therefore what we're measuring with these two curves is two treatments compared to each other. And what we're trying to do is to achieve a gap or a separation so that people are surviving longer with one treatment more than another. I'll just move on to an example of an immune therapy in melanoma. And this again is the first drug to be approved. That's ipilimumab, which is also now being trialed in ovarian cancer too. It doesn't work in everyone. It works in a fairly small proportion of patients, only about 20% of patients. But the important thing here on this graph is that the bottom axis is showing months, so as time passes. And once we get to that 20% where it works, there's no more people dying from it. So people are surviving 10 years plus on this drug if they get a response. So that brings a point that if immune therapy works well, it can work for a very long period of time. And that's different from chemotherapy and targeted therapies, where as soon as you release the drug, then there's a chance that the tumor will start escaping. Whereas immune therapy is really training our own immune system to recognize the cancer, multiply, create that long-term memory, and even without the drug, the cancer can be controlled or perhaps even cured for a long period of time. But 20% is not good enough, so we're advancing these treatments with newer drugs. So we've gone from 20% to 50% to 60% in some responses in some cancers. Again, that's not still all cancers, but that is the goal. It's to start by finding something that works and try and improve the proportion of people that will be able to benefit from it. Coming to ovarian cancer, and I probably don't have to describe the slides too much, but what we've learned from 2003 is a study that looked at what Virchow looked at 140 years ago and looked at the immune cells inside ovarian cancer tumors. So ovarian cancers that are just removed surgically, and they examined them for these immune cells, these T cells, and compared tumors that had immune cells in them to tumors that didn't have immune cells with them. And they showed there was a significant improvement that people that had an immune cells within their ovarian cancers at the very, very initial surgery survived much, much longer than patients that didn't. So that's the top right corner there. If there are cells, then the survival was much, much better when there was no immune cells. And that was the first signal to tell us that immunotherapy or immune system is important in ovarian cancer. And this is one of the first trials in ovarian cancer to use immunotherapy. So on the top graph, this is essentially the size of the tumor, either increasing or decreasing, and this is time in days. So each of those lines is a reduction in the tumor in 1, 2, 3, only 4 patients out of the 20 that were treated. But again, the same significant shrinkage of 100% shrinkage for more than a year. So a small proportion, but a very long period of control compared to what might otherwise be achieved. And there are a number of drugs now. So ipilimumab, nivolumab, all these are those checkpoint inhibitors that target those, particularly the 2 breaks that I described initially. Very, very small numbers of patients in all of these in ovarian cancer, 9, 20, 26, 124, and 12. The benefit or the response is still modest. It really only seems to work. So ORR stands for response. You know, what proportion, what percentage of patients are getting a response. So that's 15, 10, 22. And it really does depend on how much prior treatment someone has had. So when someone has received a lot of prior chemotherapy, it seems that immunotherapy is working a little bit less good. So the trials are now moving to earlier on. So one trial that is now active internationally and is looking at immune therapy after surgery for ovarian cancer and combined with chemotherapy is looking at whether giving that immune therapy up front, very early on, will achieve better outcomes than chemotherapy alone. Lastly, I really just want to point out that immunotherapy is not the same as chemotherapy or targeted therapies in terms of side effects. So immunotherapy does not suppress the immune system, so there's no risk of infection. It doesn't cause hair loss, but it has some unique side effects, and it's really overactivation of the immune system can result in accidentally attacking the body, causing a rash, causing sometimes diarrhea. They're all usually fairly manageable side effects. So really the future directions is to try and combine things. So you get one drug, you get 20%, second drug is 40%, but when we start adding these things together, combining 2 different immunotherapies, combining an immune therapy with chemotherapy is going to be the way forward in improving responses in cancers that have not yet achieved that. And in 2007, this was an example of the list of partners, combinations of immunotherapy, and within a few years, you know, some of these are approved, some of these are still in clinical trials, but again, it's that development of combinations that we're going to need. So unfortunately, these treatments are still not available today. There is no approved immune therapy treatment for ovarian cancer in 2017, and we need to wait. These expensive trials, they take time, we need to get the results, and unfortunately, you know, we have to have the evidence before we start applying this more universally. But everyone is very excited that this approach is going to make a dramatic difference in the outcomes for ovarian cancer. And if there's ever a treatment that will result in a significant prolongation and perhaps even curing some ovarian cancer one day, it will be harnessing our own immune system to do that. One new initiative to try and develop new drugs, new combinations, and new signals in ovarian cancer is something called OASIS. It's an Ovarian Cancer Alliance for Signal-Seeking Studies. It's a collaborative initiative between ANZGOG and Ovarian Cancer Australia and the Australian Ovarian Cancer Study, and essentially is trying to accelerate through funding mechanisms and peer review mechanisms to develop studies quicker in ovarian cancer. And there are 3 now studies that are in final stages of activation and will be starting this year. So lastly, this is what we need to do. We need to move away eventually from the one-size-fits-all approach of conventional chemotherapy. We're not there yet, but we need to be able to identify a patient, their cancer, what are they more likely to respond to, and provide treatment that is individualized for that particular patient. We need to go from the conventional treatments that just make that slight little push in survival, the immune therapies that are now making that flat end where people are doing well and continuing to do well for a period of time, but then we need to push up that curve higher, so a greater proportion of people are getting that benefit. So the take-home messages, there have been amazing advances in the last 5 years. Immunotherapy for cancer is probably the greatest breakthrough this century, if not ever, in the treatment of cancer. There's a lot of work to be done to improve outcomes in patients with advanced ovarian cancer and other cancers, really. But there are developments that are hopefully going to be coming through in the next few years, and that would not be possible without the generous participation of patients and their support in participating in clinical trials and in supporting research initiatives. Thank you. That's all I've got.